Clinical assessment of the venous circulation of the lower limb. Inspection. Ask the patient to stand up because veins are collapsed when someone is lying down. The majority of patients with venous disease have abnormal, visible subcutaneous veins. If these veins are dilated and tortuous, they are called varicose veins. Note the size and cause and record this on a drawing of a leg. Sites of varicosities often give a good indication of their cause. Minute and intradermal veins can appear as blue patches on the leg. Inspect these patches carefully and you'll see that they consist of a tiny veins radiating from a single feeding vein. These are called venous stars. Compare the size of the legs, especially at the ankle level, for evidence of edema. Inspect the whole leg, particularly the lower medial one-third of the leg. Venous disease affect this area first, causing pigmentation, eczema, and ulceration. Palpation. Feel along the course of the vein and feel the tension in the veins. The veins in the lower leg often lie in the gutter of indurated subcutaneous tissue. Feel the saphenofemoral junction and ask the patient to cough. A strong cough impulse, palpable at the saphenofemoral junction, indicates the valve in the subcutaneous vein that protect these junctions are incompetent. Feel along the medial side of the lower leg for tender defects in the deep fascia. These are common sites of the communicating veins. Percussion. Full veins transmit a percussion wave along them when tapped. Percussion wave is more significant if assessed in a downward manner, as this implies absence or incompetent valves. Place your finger on one hand on the lower limit of the visible veins and tap them at the upper limit. A palpable percussion impulse indicates dilated incompetent vein between the site of palpation. Auscultation. Listen over cluster of veins for bruit which remain distended while the patient is lying down. This may indicate the site of AV fistula or arteriovenous fistula. Tourniquet test. This test can show the presence and site of incompetent valves, particularly the valves of the veins that connect the deep to the superficial veins. First, lie the patient flat. Then elevate one leg until all the superficial veins are empty. Place a rubber tourniquet around the upper third of the thigh. Tight enough to occlude the superficial veins. And then ask the patient to stand up. Observe carefully. If the veins above the tourniquet fill up, but those below it stay collapsed, there must be an incompetent communicating vein above the tourniquet. If the vein below the tourniquet fills rapidly, there must be an incompetent communicating veins below it. Next, you can use multiple tourniquets at once to help identify segments of veins which contain incompetent communicating vein. Repeat the previous steps by elevating the leg and empty the vein, and place 3 rubber tourniquets. 1 tourniquet at the mid-thigh, the second one just above the knee, and the third one at the near ankle region. And then ask the patient to stand up. Observe carefully for filling up of veins. Rapid filling will indicate incompetence connecting valve. Then release the tourniquet from above, below, and again observe for rapid filling up of veins. Another test that can be done is by compressing at the junction between the long saphenous vein and the femoral junction, which is known as a Trendelenburg test.